Hi, everyone. My name is Nora Friedman, and I'm one of the child, adolescent, and adult psychiatrists here at the Lurie Center.
And my name is Nicole Simon. I'm the senior behavioral consultant at the Lurie Center.
We're so glad that you could join us this evening. We're going to be talking about self-injurious behavior in autism spectrum disorder. And we'll start by giving you a quick overview of what we hope to discuss today. We're going to, of course, be talking about self-injury, giving some working definitions, talking about the prevalence and risk factors. We'll think about the assessment process, and then, of course, spend some time talking about both behavioral and pharmacological interventions. We'll leave you with some resources that might be of help, and of course, leave time at the end for some questions. As we go along, we have some slides to present. Please feel free to enter any questions into the chat, and we'll do our best to respond to them once we finish with the more formal part of the presentation. So we look forward to having a chance to engage with you at the end. So as we start our discussion, it's helpful to have an operational definition of self-injurious behavior. So let's start by looking at some of the diagnostic categories. The first that I want to draw your attention to is what's known as stereotypic self-injury. This is a repetitive behavior. Its onset is usually in early childhood. And although it tends to be persistent and chronic, the type and pattern can shift over time. There are two specific disorders that I also want to mention. One is called excoriation disorder, and this is a recurrent skin picking that leads to lesions, and trichotillomania, which is recurrent hair pulling leading to hair loss. Another diagnostic category that is important to know about is what's called non-suicidal self-injury. And this is deliberate self-harm with the intent to hurt oneself, but not with the intent to cause death. And there are a number of different functions non-suicidal self-injury may serve, perhaps to modulate negative emotions, resolve interpersonal distress, or produce a positive feeling for the individual. This is distinct from the repetitive stereotypy, the stereotypic self-injury, and it typically has its onset in adolescence. Now, tonight, we're really going to be focusing on the stereotypic self-injury, but I do want to make it clear that individuals with autism can experience and present with non-suicidal self-injury. That assessment and treatment process tends to be different. So for this evening, we'll really be focusing on the first category. One can see a range of topographies or types of self-injury in patients with autism spectrum disorder. And individuals may present with one or with multiple types. So some of the common topographies we see are head banging, slapping, hitting, punching the head or face, hitting or banging other body parts like the thighs or arms, self-biting, hair pulling, skin and fingernail picking, scratching, eye gouging, and knee to head hits. There was a meta-analysis a few years ago that looked at 37 studies, and they came up with an estimated prevalence rate of 42% for self-injurious behavior in autism. And the range is probably somewhere below and above that, but that was sort of an estimate looking at all the data that we have up until that point in 2020. And there are some risk factors that we know are associated with the higher likelihood of presenting with self-injurious behavior for individuals with developmental disabilities. And that includes an intellectual disability with or without the presence of autism. There are certain genetic conditions that carry a higher risk of self-injurious behavior. These include Fragile X syndrome, Lesch-Nyhan syndrome, and Smith-Magenis syndrome. It's more likely to occur in patients who have significant communication and social skill delays, as well as in individuals who have higher rates of baseline repetitive behaviors like flicking, flapping. So self-injury becomes a real concern because it can impair functioning. It can impact access to services, right? If an individual is engaging in a high level of self-injury, it may make educational interventions or other kinds of supports challenging to implement. Obviously, can cause distress for the individual as well as for family and caregivers and other staff involved. And of course, there are medical concerns that can lead to injury, which requires, emergency medical services, tissue damage leading to infection, concussion from headbanging, dental issues. In very severe cases, we might have visual issues or retinal detachment. And of course, just the psychosocial impact of engaging in these kinds of behavior. So when we're thinking about the assessment of self-injury, there are several components that we want to consider. The first are the frequency. How often is the behavior occurring? Is it extremely sporadic, or does it occur with a real sort of persistence and chronicity? The patterns of occurrence. So are there particular times of day that an individual is more likely to engage in self-injurious behavior? Is it after school when they're coming home after a long day? Is it in the evenings when they're being prompted to move through their nighttime routine and having to engage in tasks like teeth brushing they may not like? Are there specific settings where the self-injury occurs? Is it just at school? Is it just when they're in crowded environments out in the community? Is it only at home? Or is it occurring actually across different environments? We also want to think about the duration and the intensity of the self-injury. How long has it been going on for? How long do the episodes typically last? Is it a mild head hit or is it a very forceful head hit, right? And are we seeing evidence of soft tissue damage and other kinds of medical concerns? One of the most important things that we can think about are the triggers. So are there medical causes or physical symptoms like pain, constipation, allergies that are potentially driving some of the self-injury? How about transitions, disruptions to the routine, schedule changes, right? That might be leading to an increase in self-injury, thinking particularly around vacations, holidays, anytime that typical routine is interrupted, travel, things along those lines. We also want to consider any environmental factors. So has there been a change in caregivers, turnover in staff or at day program, which might be unsettling the individual and leading to increased rates of self-injury? And finally, family stressors, a relocation, conflict, any kind, illness, anything that might be creating distress for the individual that is then manifested through self-injury. We always want to think about the severity, the degree of distress and functional impairment that the behavior is causing. And of course, we also need to factor in the presence of any comorbid psychiatric issues. This can be conditions like ADHD, attention deficit hyperactivity disorder, mood disorders, anxiety. All of these can potentially be contributing factors and important to understand so that when we're formulating a treatment plan, we're addressing the whole picture in a very comprehensive way.
So from a behavioral standpoint, we want to be figuring out what is causing the behavior of self-injury, and then what's maintaining it, what's reinforcing it, what's continuing to perpetuate that behavior. So to start, we want to look for a medical explanation first. I think our Lurie Center providers are fabulous at this. They're thinking about chronic GI issues, migraines, dental issues, all of those sorts of things to see, is there a medical reason for that behavior? We want to look at the circumstances that are increasing that behavior, some of the triggers that Dr. Friedman mentioned, and when that behavior is most likely to occur. And lastly, we want to consider, is the self-injury an extreme form of self-stimulation? And that self-stimulatory behavior often comes in the form of things like hand flapping or rocking, but is that self-injury an extreme form of that self-stim behavior? But to start, I want to talk a little bit about this medical piece, right? Because it's complicated and we always need to assess and address the potential underlying medical causes of behavior. So I'm going to tell a little story about this young boy, 6-year-old Xavier. Xavier is in a substantially separate public school classroom. His special educator is out for the week. And so he's doing his work. He's non-speaking. He's doing his work at a desk with his paraprofessional. And all of a sudden, he starts hitting his ear. And the paraprofessional says, Xavier, what's going on? Are you okay? And she gives him a big hug and she brings him away from his work and has him sit down in a beanbag and gives him a lollipop and make sure that he's okay. And he gets back to work, and a couple hours later, this happens again. He's hitting his ear, and the same response. She says, Xavier, what's going on? Come here, and comforts him and brings him off to the side and gives him a lollipop. And this continues for the next couple of days. The paraprofessional doesn't tell anybody, but eventually thinks, I should probably pass this along, this unusual behavior, and lets the school nurse know, who says, oh my gosh, why didn't you tell me sooner? Calls the parents and says, you got to take Xavier to the pediatrician. He goes to the pediatrician, and the pediatrician evaluates him. And what does the pediatrician discover? He has an ear infection, right? So the pediatrician treats him with an antibiotic, and the ear infection clears up in a couple of days. So my question for you is, does the ear hitting stop? Or does it continue? I can't see all of you, but I'm guessing that some of you are thinking or saying, yep, it stops because the medical reason for that behavior has been treated. There's no longer an ear infection. And others of you are saying, no, it didn't stop, because when he started hitting his behavior, lots of good things started happening, right? He got hugs and attention from his favorite paraprofessional. He got to get out of work. He got a lollipop. And the answer is, I don't know. It could go either way, right? But the point is that just because there's a medical cause of a behavior does not mean that solely treating that medical variable is going to result in the elimination of that self-injurious behavior. The environment is always at play. It's a complex interaction. We must treat the medical, and we also must be considering what those environmental and variables are and how are they impacting the behavior. So why does self-injury occur? Or why does any behavior occur, right? Behavior is functional. All of us engage in behavior that works for us in some way. A lot of times it's communicative in nature. Or an individual is trying to communicate a need or a want. And oftentimes that behavior is also learned. This is not to blame any of you as parents that you inadvertently taught your child this behavior. It's just, again, that association with the environment over time results in learned behavior that sometimes has a negative pattern. The good news is that learned behavior can be changed. All right. So the two major categories of behavior, I like to simplify things. It's to get something you want or to get away from something that you don't want. And there can be subcategories such as social, tangible, and sensory functions. But as I'm going to show you in a moment, the same behavior can have different functions. And so here we go. You have a chart in front of you that has 6 different descriptions of hitting self and 6 different functions. You may have an individual who hits when their parents, siblings, or friends are talking to each other and not paying attention to them. That's an attention function. And by the way, the positive and negative just means, do they want to gain that attention or do they want to get away from it? That would be the negative. So hitting when a peer is trying to engage in conversation and the individual doesn't want that, that's attention negative. Hitting to get the iPad or the favorite activity or toy, let's say the iPad time ends or when the iPad is in view, that's a tangible function. Hitting when they're told to brush teeth or do something that they don't want to do, that's an escape or avoidance function or a tangible negative. And hitting, because this is common with self-injury, right? This sensory function, hitting because they like the noise that it makes or because they like the feel of it. That's what we call a sensory or an automatic function. And then lastly, hitting because the contact helps alleviate the pain. That also would be sensory, but they're trying to avoid that sensation. Let me ask you this question. We have behavior of hitting self. We have 6 different descriptions and 6 different functions. Do you think the treatment is the same for each of these descriptions of the behavior? No, it's not, right? It's a particular topography, but in an applied behavior analysis type of a program, we want to understand the function so that way we can appropriately treat that behavior. But first, we need to figure out what that function is. So what are the forms of assessment? The one that's most common that many of you have probably heard of is the functional behavioral assessment, or the FBA. This involves an interview with potentially parents or clinicians, an observation period of that individual, and then various assessment measures. It leads to a hypothesis as to what the function of the behavior is, okay? The IDEA law in 2004 requires that an FBA is completed during initial assessment or when a behavior plan is requested. Unfortunately, the IDEA does not mention best practices for conducting an FBA. So sometimes they are completed and they're not done in the way that they should be. If an FBA does not lead to a solid hypothesis about the function of a behavior, you might move toward what we call a functional analysis, an FA. This is more experimental in nature, where environmental variables are manipulated, and the goal is to try to turn on or off that behavior. This can be very time consuming. You need to have experienced clinicians who are designing an FA and implementing it. And there are ethical considerations, right? If you're turning on and off behavior like self-injury, there could be a risk of somebody getting hurt, that individual getting hurt, and that's certainly not what we want to have happen. And then lastly, I just want to briefly mention a newer type of assessment called the practical functional assessment. This is about 10 years old, also known as the ISCA, Interview Informed Synthesize Contingency Analysis. And this is where we look at conditions in which the individual is happy, relaxed, and engaged, right? So they're doing their favorite things. They're on the beanbag, watching an episode of Peppa Pig while eating a bag of Doritos, like the best case scenario. And then we're understanding through an interview process, what are the conditions where they're most likely to become agitated, but also what are those very first signs of agitation? And so we're still looking to turn on and off the behavior, but we're not waiting till it gets to the level of self-injury or aggression, for example. We're waiting till just maybe that initial scream or that sort of very more minor sign of behavior, then we can shut it off again. These types of assessments are quick, safe, and reliable and seem to be more commonly used today. So data collection is always going to be important, especially when we're talking about self-injury. You'll see it. You see a number. By the way, as I'm talking, on the right of your screen, you have a list there of data collection apps. If you use an app to collect data that you like, please put it in the chat. This is an opportunity to share resources, and we're always looking for families to learn from each other, and we like to hear from families about this as well. But low rates of behavior may be tracked with a frequency or episode count. A high rate of self-injury may be a frequency count in a clinical setting, in which case, and you see a picture of one there, a clicker might be used. I've been in some private, more intensive settings where you'll see staff who have clickers attached to every belt loop on their body because they're tracking multiple topographies at once. This is not anything we'd ever ask a parent to do, but you'll see intensive settings who are really trying to get that accurate data. And when you're using a clicker, you're talking about generally hundreds to thousands of counts of self-injury potentially in a day. Episode count obviously is going to be easier if you're looking at sort of the full episode of behavior. And then there's also time sampling for higher rates of behavior. That would be how many, does the behavior occur or not within, let's say, a 5-minute block or a 10-minute block or a 30-minute, et cetera, plus or minus. I think electronic is where we're heading. Oh, by the way, you see up there on your screen, the paper and pen version. This is more of an old school, something you might see in a school setting, a week's worth of behavior, a couple of examples, frequency count, duration. That's fairly standard, but not very sophisticated. But many programs out there and even schools are looking at electronic applications. Either they've developed their own or in terms of families, you might even be using the notes section on your phone. You may use a Google Doc that can be shared with other providers or an Excel sheet, or as I said, some of the apps that I have listed there. Lastly, documentation of injuries is so important for self-injury. So you see that picture of a person there, or a shadow of a person, outline of a person. This could be used in a program. It could be used in a family home to just document the injuries that might come along with the behavior. When it first happened, what it looked like. This is especially important because what can sometimes happen for those of you who are parents of individuals who engage in intense high rates of self-injury, you might find a new mark when they come back from their day program or come back from school. And the general explanation will be, well, they engage in self-injury, right? We don't really have to think about that or where it came from because that individual engages in self-injury. And we want to make sure that we're not sort of using that as an excuse, that we're understanding what the behavior is, that we're tracking it over time, and that any mark is investigated and explained and incident reports are completed, so that we know that our child is safe in whatever setting they're in. Okay, so those are just a variety of tools that can be used. Treatment. As I mentioned, number one, we want to be treating the underlying medical causes of self-injurious behavior. I'm going to focus now on behavioral interventions. So the behavioral interventions that are based on the principles of ABA, applied behavior analysis, and are a set of them that are proactive and reactive and then protective. And then at the end, Dr. Friedman will talk about medication treatment. Some sample proactive strategies. I always start with the basics of healthy eating, movement, and sleep, right? These are variables that impact all of us when we're not sleeping well or not eating well and not getting enough exercise. We're all going to be crankier. And so let's start there as far as being proactive, right? Then what does that environment look like? Is it therapeutic, positive? Are folks engaged? Is the day structured with meaningful activities? Many of you, all of us, experienced what life was like, when COVID first hit, when there was no structure to the day. Everything was canceled, right? And how challenging that was, especially for your children, right? And so today, maybe more activities are back in place, but we see the differential on weekends versus during the weekday. Weekends can be a little bit less structured. That can be more challenging. Other supports that can be helpful are visuals. These might be pictures or photos or words, again, depending on how the individual best learns and can best be supported. They might benefit from timers, and then certainly choice making whenever possible is recommended as a proactive strategy. Some more specific proactive, or what I'd call antecedent strategies. So again, this is what would happen before the behavior. Probably the most researched and most successful intervention that is in the literature is called functional communication training. This is replacing the self-injurious behavior with a functionally equivalent communicative response. What do I mean by that? Here's an example. If that individual hits themselves when they see an iPad, we are going to teach them how to communicate requesting that iPad, all right? They hit themselves when they're doing work, we may teach them to communicate break, right? So it directly relates to the function of that behavior. And by the way, they may not be able to say break or say, I want a break, but maybe we're teaching them to touch a symbol to communicate the need for a break. That strategy is well known, well researched, and can be very, very successful in terms of mitigating self-injury. Minimizing triggers, going back to the example of you may have somebody who's hitting themselves when they're doing work. Not only is it important to teach them how to communicate that they need a break, we also need to look at what is that work? Is it too hard, right? Do we need to simplify that work? Is the work expectation too long that we're asking them to work for 15 minutes when they're really only able to do 2 minutes? So antecedent intervention is to look at what are the expectations and does it match the level of where that individual is at. Non-contingent access to the reinforcer. Let's say that the function of the behavior is attention seeking. We don't want the only time that individual gets attention to be when they're engaging in the self-injury, right? And then everybody rushes over to block the behavior or to intervene. We want to make sure that that individual has access to positive attention throughout the entire day. That can help minimize the attention that they might be looking for by engaging in the negative behavior. Offering a functionally equivalent replacement activity. So again, you've got a sensory function for the self-injury. They're banging on walls or tables, and maybe they like the feel of that or they like the sound of it. Well, what if instead of a harder surface, they're banging on a drum and it becomes more of a functional activity, and they get that same feedback that they were getting from engaging in the self-injury. And then lastly, teaching new behaviors or skills. These could be things that are incompatible with the self-injurious behaviors, such as you have somebody who has difficulty and engages in self-injury during transitions, and we teach them to transition with their hands in their pockets. Or relaxation strategies could be another example of something that can be helpful proactively, where we're teaching them how to keep their body calm throughout the day, and then could also be helpful once they've learned that when they become upset, that they have a strategy where they can calm down. So those are some more specific examples of antecedent strategies. Reactive strategies, I will say probably the most common reactive strategy that you'll see in a behavior plan will often start with response blocking. And all that means is that physically blocking the behavior from occurring, okay? So an individual engages in, let's say, head hitting, and we're going in to prevent them from doing that physically. I will say this, that because I do get the question oftentimes around, well, if I don't intervene and I don't block, he might start to bang his head, but then he'll eventually stop, because generally there's an attention function there, right? So if I ignore that behavior, it'll stop. Is that okay to do that? And the answer always comes back to injury, right? We have to assess the level of risk of the injury. And, it might be okay to not intervene physically for a couple of hits against a mat, for example, or a matted surface. But if that child or adult is in a parking lot and the head banging is going towards concrete, that's a different story, right? We're not going to be able to ignore that behavior. So it's a fine line and something that would need to be evaluated for each individual. An incompatible activity, all that means is something that the individual is engaging in that they're not able to also engage in the self-injury. So oftentimes this is going to be doing something with their hands if the self-injurious behavior is typically executed with their hands. So again, if it's head hitting or biting, anything like that, and you're able to give them an activity, doing a puzzle, pushing the trash barrel outside, holding onto a book, putting hands in pockets, something where they cannot do both at the same time, that can certainly minimize the self-injury. And then the biggest category certainly are function-based interventions that are based on behavioral principles with modifications for safety. And so in this chart, I'm not going to go through this chart, but I think we'll be sending out the slides after the talk, so you'll be able to see this. The first two columns are the same as what I showed you before, those 6 different descriptions and the 6 different functions. And then that third column are treatment examples. In green, you see the proactive strategies. In red, you see the reactive strategies. And I'm just going to go through a couple of examples so you can kind of see the difference, starting with the attention function. That we mentioned this, or I talked about this a little bit earlier. We want to make sure we're giving ample attention throughout the day. We want to teach a better way to gain attention. Maybe we teach a tap on the shoulder, request to play, or touch a play symbol, for example. And the reactive recommended strategy would be, for an attention function, planned ignoring or a timeout from reinforcement, meaning that we're not drawing attention. Now, with self-injury, we have to be careful, and this is where the modifications come in, right? The functionally appropriate response may be to ignore that behavior, but we're talking about self-injury. We can't just do that when there's a risk of injury. What does this mean? It means that we might need to block that behavior casually without having a big, maybe verbal reaction, without, being as casual as possible, and maybe not having a dialogue during the intervention, right? So that could be an example of, we modify it a little bit. We are providing some attention because we have to, but we're trying to minimize the attention that we're providing. Jumping down to hitting when told to brush teeth. There's a whole host of proactive strategies we could consider for this one. We make the activity fun because we get a special toothbrush or a special flavored toothpaste. We might modify the expectations initially, like instead of going for the full dentist recommended 2 minutes, we're starting with 5. Just touch the toothbrush to your teeth, 2 seconds, 5 seconds, build over time. We might increase opportunities to practice brushing. So again, instead of 2 or 3 times a day, maybe we put that on the schedule every hour so that that individual gets more practice and gets more exposure. Or we may set up a highly reinforcing activity to take place after the toothbrushing is completed, essentially as a reward. What we are going to make sure to do reactively is maintain that expectation of brushing teeth. The second we pull away that expectation of brushing teeth, that individual has learned that when I engage in this behavior, because I hate brushing my teeth, I don't have to go back to it. But what's my caveat for this, right? We may have to take a pause. We might have to take a pause in that toothbrushing sequence to manage that behavior, right? We're talking significant self-injury. We can't power through that and continue to brush teeth. It would be unsafe. So what do? We make sure that when that individuals come, that we go back to it, even if it's just an approximation of the demand, just so we are showing them that we've done a little bit of it. That would be appropriate. So what I'm trying to explain is not only are we making sure that we're trying to have a functionally equivalent response, but we are sensitive specifically to how self-injury is a little different, and that we need to make sure that everybody's safe, and that might impact a little bit how able we are to do a true functional response. Okay. All right, and so I'm going to talk now about some of the protective strategies that are out there. The padding is the most benign protective strategy available. You'll see this in programs, you'll see this in schools, that if you have an individual who engages in, let's say, headbanging behavior, you might see a pad right directly on their desk or on their workspace. You also might see padding behind them. So that way, if they were to engage in behavior, there's an automatic layer of protection built in. Padded separate spaces are seen in schools and programs as well. Those can be controversial. There are certainly clinicians out there and just, school administrators, all sorts of people who just absolutely don't agree with this type of a space. But what I would say about it is that if it can add a layer of protection, and we're not, especially with self-injury, it should not ever be used as a place where an individual is going in and we're then stepping out, right? If an individual is going into that room, the way I would view it is they're going into that room because there's extra padding and protection, and they're going to have somebody available to intervene as needed, right? And so I just want to make that point very, very clear that anybody who has the potential to engage in SIB needs to be closely monitored and should not be left alone in a room, even if it's padded, when they're agitated, okay? Mobile pads, that's just essentially something that's small enough to carry with you. So if you're going out, into the van or into the community, or we're out to recess, whatever it is, we want to have something with us potentially for that transition, and for when you get out there. And bean bags can be used as well as both a seating area, but also as additional padding if needed. So that's pretty benign and least restrictive in terms of protective strategies. Something that's much more restrictive are protective holds. And so protective holds or restraints, I'm using those words interchangeably, may need to be used to prevent injury for an individual who engages in self-injury. I want to make a couple points about this. Anybody applying a protective hold should be properly trained, okay? That's absolutely any staff people that are working with your child. And I'm very excited to say, and some of you may already know this, that we now offer parent training in protective holds and restraints at the Lurie Center. And so this is something where now parents have the availability, at least with us, not really many other places, but they have the opportunity to learn proper and safe methods to hold their child. Okay, the curriculum varies in different programs. I would say that CPI and safety care are the two most commonly used. And of course, protective holds should be used as a last resort, given the risks associated with them. The pictures that you see in this slide are examples from CPI's Nonviolent Crisis Prevention Intervention Program, and they are examples of two holds that could be used. One's clearly a one-person design for a child, and one that could be used for an adult that's a two-person technique. And these are a couple of examples of the techniques that I teach during the parent CPI training class. And then lastly, I wanted to talk about protective equipment. This is equipment that is worn by an individual, and it's designed to protect them from self-injury. So you can see a lot of examples here: helmets, mitts, immobilizers, etc., harnesses. Before you write in the chat and ask me, where do I get this equipment? What's the best place to get it? I am not going to answer that question. And there isn't one set places where, these types of items are purchased. An experienced clinician absolutely should be involved in determining which equipment is needed, where to get it, how to modify it. Okay. And the reason is, and really this experienced clinician piece is important in all of this, but there are risks in the use of protective equipment. I'm going to go through a few of these. They are, it can be difficult to administer, right? You have individuals who are agitated. They do not want a helmet put on their head. They do not want gloves put on them or mitts. And that resistance not only can lead to more self-injury, it can also lead to physical aggression. So there's a big risk there. There's the risk of getting tissue damage from the equipment. This equipment oftentimes is not designed to be worn by individuals engaging in self-injury. And so it may not fit properly. It may not be meant to be worn over the course of several hours. So there's a risk there. This is a big one, the reliance on equipment. If you have an individual who has self-injury but also anxiety around that self-injury, they might feel comfort in having some form of a protective equipment like a helmet. And in a sense, that's good, because when they're wearing it, they might be less likely to engage in the behavior. However, when you take it off, you might see an increase in anxiety and an increase in the behavior. And what happens over time is it becomes extremely difficult to remove that equipment. They do not want to remove it. Then the folks working or designing the program don't want to remove it, because that just means there's high rates of behavior, and the parents don't want to remove it because there's high rates of injury. And then you have somebody who's wearing a helmet 24/7. And so these are real side effects that if you don't have somebody who knows what they're doing in designing this program right from the beginning, it can lead to that, and we want to be very careful with the design. Certainly, and that sort of speaks to, if you don't have experienced folks designing the program, it can be poor programming without a plan to fade that equipment. And there are social considerations in that not every program out there is going to be comfortable serving an individual who is wearing protective equipment. So some of the considerations for protective equipment: have less restrictive interventions been tried? Is that clinician or BCBA experienced in severe SIB and protective equipment? Will the staff be trained and monitored? And is there a clear plan that includes when do we apply it? When do we remove it? Are we monitoring that skin integrity? And how do we fade that program? Just as a side note here, schools and programs do require doctor's orders for protective equipment, and adult service agencies require approval from the Human Rights Committee. So these are just pictures depicting sample equipment fade. You have a long Kevlar sleeve, right? That material that you can't really bite through, goes all the way up to the fingertips and past the elbow. And that fades to just the wrist to the elbow, which can then fade ultimately to a sweatband. By the way, there could be 10 or 20 steps in between. You could be chipping away inch by inch as fading steps, but that's one example. The other is the hard helmet with a face shield. That is the most restrictive form of a helmet, that goes to then one that's more of a soft shell, but still fairly restrictive with a chin strap, to one that looks kind of like a horseback riding helmet without the chin strap, to a baseball cap. So that would be the goal, right? There might still be that feeling of protection, but certainly a baseball cap is going to be a lot less restrictive than a full helmet with a face shield. So before I turn it back over to Dr. Friedman, I just want to say that when it comes to behavioral treatment of SIB, I can't emphasize enough the importance of having an experienced clinician guiding the programming.
Thank you. So let's spend a few minutes talking about medications before we get to any questions. The first thing that I like to think about is, based on our assessment and understanding the frequency, the intensity, the duration of the self-injury, is, do we need what's called a standing medication, something that you take regularly at a scheduled time? versus an as needed, or what's known as a PRN medication. That's something that you take situationally. So if somebody tends to get very anxious before blood draws and they need a PRN medication to help them stay calm and minimize the risk of self-injury during a procedure, phlebotomy. Of course, we always want to be attentive to any co-occurring behavioral, neurological, and/or psychiatric issues that we can target that might help drive down the rates of self-injury. So, thinking about sleep disruption, which is so common in the ASD population, ADHD symptoms, impulsive behavior that obviously can increase the rates of self-injury, anxiety, seizures. All of these are considerations when we're thinking through how to intervene medically. And always we need to think about the risk-benefit ratio. I want to highlight that most importantly, these are really individualized discussions and decisions for a given individual, family preference, the patient preference. And so it involves a lot of hopefully discussion with a prescriber that you have a good trusting relationship with. So I just want to highlight some of the classes of medication that we can think about in terms of targeting self-injury and associated issues. But obviously more detailed discussions are sort of beyond the scope of tonight's talk. The first class is what's known as alpha agonists. These are medications called clonidine, guanfacine. They're also long-acting extended release preparations, which go under the brand names of Capvey and Intuniv. Those two in particular have approval for ADHD treatment. But these are really effective medications for impulsivity. And sometimes they can be an interesting way to try to get at issues like self-injury without using medications that carry more significant side effect profiles. We'll often see high rates of comorbid anxiety in the ASD population, and it's possible that anxiety can be a contributing factor to problematic behaviors like self-injury. And I've listed a whole variety of different medications that we consider anxiolytics or anxiety-reducing medications. Anywhere from benzodiazepines to the selective serotonin reuptake inhibitors, or the SSRIs. In many ways, the class that's been studied the most robustly are what's called the atypical antipsychotics. And I'll share more about two particular drugs in this class, aripiprazole and risperidone, on the next slide. And then we may think about mood stabilizers. These are anti-epileptic drugs that are often used in psychiatry for mood or behavioral stabilization. Those are medications like valproate, known as Depakote, and topiramate. So I mentioned the atypical antipsychotics, and the reason why this is often the focus of conversations about medication is because there are two medications in that class, risperidone and aripiprazole, which are the only two medications that have approval from the Food and Drug Administration for the treatment of irritability, including self-injury in ASD. So they have a very strong evidence base supporting their use in this population. Unfortunately, they come with what can sometimes be a very challenging side effect profile. So they can cause things like sedation. They can be associated with appetite increase, which can lead to weight gain. And that can also contribute to metabolic issues. So elevated cholesterol and lipids, high blood glucose, putting patients at risk for developing diabetes, elevated prolactin, which is something we see specifically with risperidone. Prolactin is a hormone that can be associated with disruptions to the menstrual cycle, sexual side effects. These medications can cause a whole array of different movement side effects, a slowing of movements, abnormal involuntary movements, often of the face or mouth area, tremor, sustained muscle contractions known as dystonia. So these are things that we want to monitor for anytime a patient is taking these drugs. And the atypical antipsychotics can also be associated with reduced bone density. So a whole host of potential side effects, which means that we need to think really carefully before deploying these meds about whether or not their use is indicated. I just wanted to highlight one other medication. It's N-acetylcysteine. It's actually an over-the-counter supplement. It's an antioxidant that modulates glutamate, one of the neurotransmitters in the brain. And it has been studied in a number of different psychiatric conditions, including trichotillomania, excoriation disorder, and ASD. Certainly does not have the robust evidence base of medications like risperidone and aripiprazole, but it tends to have a pretty benign side effect profile, can cause nausea or vomiting, diarrhea, and sedation. And so sometimes that can be an interesting option for families who are particularly wary of the antipsychotics and their side effect profile. And so I just want to leave you with some thoughts on general considerations for medication. We always want to think about, those drugs that may have more benign or desirable side effects. So if you have a patient who's engaging in a lot of self-injury, and they also have difficulty falling asleep, you might want to use a medication like clonidine, which can be sedating. And so it can help individuals get to sleep more easily, and then can also potentially have beneficial effects on behavior. In general, with this population, with pediatric patients in general, the adage of starting low, going slow is really helpful. We want to try to use the lowest possible dose of a medication that has a therapeutic effect without causing unnecessary side effects. And for that reason, it's also helpful to make one medication change at a time. Unless we're very hard pressed and in a really kind of crisis situation, making one adjustment allows us to really disentangle whether that drug is having a benefit as we adjust the dose. And that requires, of course, people to be patient, and it's really challenging and distressing to see an individual engaging in self-injury, particularly the more intense varieties of that, but sometimes patience is what's needed. We want to monitor for adverse effects. We want to think about nutrition and physical activity, particularly for the antipsychotics, given their metabolic side effects. And we want to constantly be assessing the risk and benefit ratio of a given medication. So we may have started it when the self-injury was very high, but now through wonderful behavioral interventions, thanks to Nicole or other behavioral providers, maybe those rates have actually become much lower. And so the need for standing medication has been eliminated, and we can get away with other options. And to that end, we're going to try to attempt to wean or discontinue the medication at regular intervals. We may not be successful. We may find that an individual really needs to be on a medication long-term, but we won't know that unless we try. And finally, we just want to leave you with some resources. We have a couple ones up here. There's a challenging behaviors guide through the Autism Speaks website, a parent's guide to applied behavior analysis, also a helpful medication decision aid for those of you who are thinking through the risks and benefits of starting a drug. And then the practical functional assessment that Nicole mentioned, that link is to a website that offers a whole array of information about resources and support for practical functional assessment.
We also wanted to mention some of the behavior and safety classes that we offer at Lurie, and I love the endorsements in the chat. So thank you to folks who shared that they have had good experience in those classes. We have a behavior basics class. I covered some of the elements in that class today, but intro to ABA, reinforcement and limit setting, and sort of troubleshooting ABA. What do you do when the program's not working? We have our parent CPI class, de-escalating challenging behaviors. That includes that physical intervention training. We have also a version for folks who have children who do not experience physical behaviors. That's just the verbal and nonverbal de-escalation techniques. And then we have a safety at home and in the community class. Anybody interested, these are open to the public. And so you can call the Lurie front desk to register or send us an email. And then I also offer behavioral consultation, outpatient consultation trainings, homeschool and community observations for folks of all ages that may be insurance covered. And we also have a self-pay option. So again, if that's something you're interested in, feel free to reach out and we can figure that out with you. And I think we are ready to take some questions. So I'm going to stop my share so we can all see each other. Okay.
I'll share one question while others are putting theirs in the chat. What are your thoughts about self-harm among those on the autism spectrum with the diagnosis of borderline personality disorder? Do you think someone can have both?
Sure. So I think that's a great question. And it goes back to what I mentioned at the start, that we see that phenomenon of non-suicidal self-injury in patients with ASD. And it's important, I think, to differentiate that from the kind of self-injury that was really the focus tonight, this stereotypic self-injury. And that's because the treatment approach to non-suicidal self-injury often, it involves behavioral components. It's a very critical piece of it, but it's through a slightly different lens, through usually principles of dialectical behavioral therapy, which is an offshoot of cognitive behavioral therapy, focusing on distress tolerance. There are some overlapping features like finding substitute behaviors to replace the self-injury. So it absolutely can occur, and it requires a different approach than I think the one that was the focus specifically tonight.
I'll take the next question that's in the chat. How often is SIB due to sensory needs? If an individual is engaging in SIB to satisfy a sensory need, do you have tips for how to find an appropriate sensory stimulus? And then how do you help the individual integrate this replacement into their daily life? So I don't have a percentage on that. I actually was trying to look that up to see if it fits into one category or the next. I know that we certainly see it a lot. And what I can tell you is that when sensory is the function, it can be the trickiest to treat because it is the hardest to find a replacement for, partially because we don't necessarily always know what exactly it is about that behavior. We might know there's a sensory function, but what is it that they're getting out of it? Is it the feel? Is it the smell? Is it the noise? And so it can, and without that individual being able to tell us, it can be really difficult to replicate. But oftentimes it's a trial and error, right? So like I gave the example of the drum or, different things like that it might be a trial and error to see, is there something that will replace it? It oftentimes doesn't do the full trick because we can't get it exactly right, but it might help mitigate the behavior to a certain extent. And then how do we help that individual integrate this replacement into their daily life? Part of it goes back to sort of that non-contingent application. So going back to that, if we find that, okay, there is some sensory component around the feel of the banging, and we can, replicate that, for example, with the drum, let's give them access to that, throughout the day so that they can engage in that behavior as opposed to looking to do that in the self-injury. But that's sort of a simple example. It's complicated. It can be really hard to figure out something that replaces that sensory function. Lots of trial and error, and then non-contingent access is what I recommend.
I'm happy to respond to the next one. How do you assess mood disorder or migraines? My son tends to calm down after receiving pain medication. So the mood disorder question is, I think, probably a longer answer than we have time for tonight. But just to give a quick response to that, especially in individuals with limited communication skills or who are nonverbal, we're going to have to rely on objective assessments from people around. So often mood disorders can be associated with a change in sleep patterns, a change in appetite, a change in energy level. We may see episodes of tearfulness that are coming on when that wasn't something that had been occurring at baseline for the given individual. So it's a tricky process, but really I think having a sense of the symptoms that we're tracking and being able to see, is there a change from how the individual was presenting just a month ago or a year ago? The migraine issue, again, and if we have patients who are not able to communicate effectively, then sometimes we do have to rely on what I call these empiric trials, giving ibuprofen when it looks like they're in distress. And if we see that that is helpful, it lends support to the idea that there's something medical or physical that's causing them discomfort. And specifically for migraines, do they show sensitivity to light or to sound? Like, are they going into a dark space? Are they lying down napping? Do they seem to be in a better space when they wake up, right? Things that are kind of consistent with how somebody with a migraine might feel. Is there a heavy family history of migraines? So those are all clues that can help us to hone in on what might be contributing to pain.
Dr. Friedman, do you want to take the next one about clozapine? Just
Yeah,
down in order here.
I don't think I have particular data with the use of clozapine specific to self-injury. Clozapine is another atypical antipsychotic. It has its own sort of unique and challenging side effect profile. It requires a heavy amount of regular blood monitoring. It can be very effective. It's used for treatment of schizophrenia and psychotic disorders, and can also be used for some indications in autism, but I don't believe that there's specific data looking at that in terms of self-injury.
Okay, a lot of questions I'm going to try to tackle here. Yes, self-injury is more common in individuals who are non-speaking or have difficulties with communication. In terms of this question around perfectionism, what I would say there is that that's what we need to address, right? Is that perfectionism, and how do we help that individual cope with being able to make a mistake, right? Practicing that, sort of probably anxiety is in play as well. How do we treat that component and help them to accept that as part of the treatment for self-injury? So I wouldn't necessarily break it down into strictly task avoidance and attention, but we need to kind of target the issue directly there. Could self-injury occur purposeless or as a result of boredom? So as I had mentioned when I was talking about the need for structure, absolutely. In the absence of activity, meaningful structure, and enjoyable activities, we might see self-injury more likely to occur there. Recommendations for skin picking that occurs during the night. Yeah. Okay. Or in the shower when my teen is alone. This is really challenging and somewhat common too, the sort of behaviors that occur overnight. And it can be all different kinds of self-injury. I know of programs and family homes where they install cameras to sort of watch for this, right? Because just because nobody's there doesn't mean that it's not happening. And you're not always there to supervise. And so it depends on what that behavior is for sure. There could be protective equipment that would minimize that, but it depends on if they'll keep that protective equipment on. For example, skin picking, oftentimes the most commonly used protective equipment or gloves, but if that child is just going to remove the gloves, then it's not going to be as effective. So, we'd need to sort of get more into the specifics, but we'd be thinking probably about protective equipment. And then also, is there any other, are we able to not supervise, or do we just need to provide the supervision if the risk of injury is so high? Let's see, Nora, do you have?
Yeah, so I think we have
jump in?
time for, unfortunately, one more question.
Okay.
And so somebody posted about an individual who has really significant and high frequency head hits, which has caused, it sounds like, some permanent bumps on the sides of the head. And I've seen a number of doctors, including neurologists, who have not felt that a brain scan would be beneficial, and asks about thoughts on imaging and self-injury. And I think this is a really important question, and actually a very hard one to answer, because it's so contingent on the particular individual in this situation. I don't want to overstep if 5 neurologists have evaluated this individual and felt that imaging was not necessary. The things that I would be thinking about if I heard the story was, aside from the soft tissue bruising, have there been changes in the patient's neurological functioning, right? So sleepiness, regression in skills, things that make us concerned for some underlying process in the brain that would merit a further workup. What I can tell you is that somebody who, and I'm sure Nicole could say the same, we treat patients with really severe and significant self-injury, and we are not routinely getting head imaging on them. So again, we're looking for changes in baseline that suggest there might be something going on that requires a more urgent neuro assessment. So I think we're out of time for the evening. Thank you all so much for joining us. And sorry, we could not get to all the questions, but we appreciate everybody's participation tonight.